Yeah, looks
Perfect.
good to me.
We see like the preview display.
Is it the presenter mode? Yeah.
Let's just do a little swap there. All right, so let's get things started. So welcome everybody to night 5 of our Trauma Nights series in conjunction with MacOrtho and the Canadian Orthopaedic Trauma Society. We've had a chance to connect with lots of people through our MacOrtho network, as well as reaching out to our COTS group, and that really gave us access to a global group and network, global network of trauma specialists that we've been lucky enough to get some insights from. We've had just had our last week's session was a case series, our first one, where we just went through cases discussing the first 3 weeks of topics in orthopedic trauma, and it was really interesting. We got some really great discussion with Dr. Tefescu and Leighton and Dr. Koshman, and to discuss some interesting polytrauma concepts. And we're back in it to our dedicated topic sessions, and today's going to be a nice discussion of proximal humerus fractures. And actually, before we get into it, I just want to put a plug in for some hot off the press evidence from 2 of our residents at MacOrtho related to some trauma work. Actually, Dr. Dan Axelrod, one of our residents, just wrote a review on the Canadian Orthopaedic Trauma Society experience of research, and that's in the British Journal, British Joint Journal, who posts the link to that. And Marie-Anne Gauthier had a review on hip fractures and peripheral nerve blocks, and that sort of ties into one of the sessions we just had. And so, you know, those links will be available, and then I direct you guys to some hot off the press evidence. Some housekeeping items, just as we are recording, as you all heard, so hopefully everybody's okay with that. As the discussions are being presented, please keep on mute and keep your videos. Choose to keep them on or off, however you like. But hopefully we're going to be directing the attention to our presenters. And when it's time to interact, go unmute, ask questions in the chat, and we'll all be watching it. So, you know, a brief introduction to tonight's topic. You know, we're Dr. Joe Hall, one of the orthopedic trauma surgeons at Hamilton General Hospital at our Level 1 Trauma Center, and we have a group of surgeons that sort of cover our Level 1 call for the area. But that's really, you know, just one of the hospitals that are part of our trauma network and orthopedic care in the region. And we cover a large catchment area, and we have MacOrtho faculty spread throughout. And we're lucky enough to have 2 of our Oakville staff joining us tonight to moderate the evening, Dr. Heather Brien and Dr. John Haverstock, who are orthopedic trauma specialists at Oakville Hospital, part of the MacOrtho family. Lots of our residents actually go out to do rotations with them in community orthopedics and upper extremity, and have had excellent experiences out there. And we're really lucky to have them moderating tonight. They're both trained at Western Ontario and the HALT, the Hand and Upper Limb Center there, and it's kind of a Western themed evening, as they're going to be moderating our discussion and interacting with our panelists, Dr. Emil Schemitsch and Dr. Mike Gardner. And so Emil Schemitsch is professor and chair at Western Ontario University Schulich School of Medicine. You know, has just had such an impact in Canadian orthopedics. A lot of his work has been at the University of Toronto, and he's worked tightly with Canadian Orthopaedic Trauma Society from the very beginning. Past president of the Canadian Orthopaedic Canadian Orthopaedic Association, and also heavily involved in the Orthopaedic Trauma Association leadership. And we're lucky to have him tonight, as well as Dr. Mike Gardner, who's joining us all the way from California, the Best Coast, and he's the fellowship director and a full professor at the Stanford Orthopedic program. He's the chief of the orthopedic trauma group there, and as well as the fellowship director, and really heavily involved with the OTA as well as AO. You know, he's a master educator, and we're lucky enough to have him share insights tonight. And so, well, I'm going to turn it over to our moderators, and I'm going to stop screen sharing and turn it over to Heather and John, who will start by introducing our topic, as well as carrying on the rest of the evening. And I'm going to take a step back.
Thanks, Herman, and really appreciate you asking us to moderate tonight. And thanks to our speakers for coming to participate. We're going to start it off quickly with a case Dr. Haverstock is going to present, followed by the speakers, and then a bunch of cases at the end. This is just a case to get you guys start thinking about this type of fracture and how to manage it.
Okay, thank you.
I think one of you will have to leave the room or just use one computer, because there's quite a bit of feedback there.
Sorry, we're just having some feedback with the overhead Here we go. Yeah, very excited to participate. Just a little case to start the ball rolling so residents can maybe think of some pertinent issues as our experts are presenting later. My favorite fracture, the proximal humerus fracture. Here's a case of Mrs. Jones. She's 68. She lives alone. She actually has schizophrenia, and she fractures her hip, and she has a hemiarthroplasty done.
Gray, pneumatic tube system, main pharmacy, send only, code gray, pneumatic tube system, main pharmacy, send only, code gray, pneumatic tube system, main pharmacy, send only.
Those are the only codes we really have in Oakville here, so I apologize for that. So yeah, is there a PGY2 resident that wants to comment on these X-rays from a woman who's also had a hemiarthroplasty on the same side? Who can point out a resident for me?
Let's go Jeff K, actually. That's his name.
How about
Yeah, sorry.
Jeff K?
Can you hear me?
Yep, go right ahead.
Jeff, can you hear me?
Yep. So right AP lateral shoulder. Looks like there's a four-part.
Can anyone suggest a junior resident just to comment on these X-rays?
I think Jeff's doing it right now.
Is anyone else hearing me?
Yeah, I can hear you. Jeff, you're on target. You want to keep going?
Yeah, sure. So it's looks like a four-part proximal humerus fracture.
Okay.
It's relatively displaced. The alignment's in varus. It's hard to tell whether there's also a subluxation or dislocation of the joint. So ideally, I'd want to get an axillary or valpo view.
Okay, sounds good. Sorry, I was just having some volume problems there. Yeah, so I would say definitely, well, three-part, perhaps four-part. Hard to comment on the lesser tuberosity, I would say. So what's your treatment option going to be for this woman who's also had a hip fracture and has some significant mental health issues, lives alone?
In a patient like this, you start to think about probably some arthroplasty options, whether it's a hemiarthroplasty or reverse total shoulder, just based on the fact that you have a displaced either 3 or 4-part fracture. She's elderly, also has other medical comorbidities. Her bone quality isn't great. I'd want to assess see what her shoulder function was before, but probably in her case, go straight to a reverse total shoulder.
Okay, fair enough. In her case, personally, I suggested sling treatment. I felt that the lesser tuberosity was in a good position. The greater tuberosity was fair, so I thought it had a fair chance at healing with sling treatment, and her comorbidities were a bit concerning. I figured she'd be in the hospital for 6 weeks no matter what I did. At 6 weeks, she continued to have pain, and her imaging shows. What do you think about her X-ray there, Jeff?
It looks like there's been interval proximal sort of migration of the shaft into the head. There is some callus forming, it looks like. The alignment is a little more in varus now.
And what do you think about her tuberosities? Have they shifted at all? You can look at the CT scan on the right, just one selected view, I know.
Maybe a little, not too bad actually.
Yeah. Okay, so for this woman, she's now 6 weeks out, having a fair bit of pain. What do you think we should do? Should we continue with the sling treatment and expect that it's going to help, or should we change course?
I'd involve a discussion with her at this stage. Now that you're already 6 weeks out, I think what you can try to do is see if she does get any better, and then plan for that reverse total shoulder if there isn't any improvement. Since
Okay.
we've sort of already gone towards the non-operative route, we could see if it does get a little better in the next 6 weeks.
Okay, good. Yeah, this is one that I'd like to hear eventually what the experts think. I mean, for me, the tuberosity looks like it's the greater tuberosity is migrated a bit posteriorly, not too superior for expectations. They didn't have any shoulder problems beforehand. So we went on because of pain and general disability to do a reverse. And what do you think about this result on just these two x-rays? What can you comment about this reverse, Jeff?
The cemented long stem reverse, in terms of alignment and position, looks good. I don't really see any obvious complications or any issues. It's good inferior tilt of the glenosphere.
What do you think about the tuberosity specifically, the greater tuberosity?
Looks like it's healed and sort of restored into its location.
Yeah, I agree. So I think this is a pretty good result for tuberosity healing, and I think that's probably the most important part. So just a few things to keep in mind to get the ball rolling. Is Dr. Schemitsch, thanks very much for joining. Dr. Schemitsch is up first.
So I'm going to just share my screen, I guess. So hello, everyone. I'd just like to thank the organizers for inviting me to speak. I thought the case was excellent. I think it really represents some of the issues that I'm going to talk about. I think there's a lot of controversy, not so much even around what type of operation, but whether even patients should receive surgery for proximal humerus fractures. So I'm going to try and go over some of the evidence around that. So just for some context, proximal humerus fractures, they're the third most common fragility fracture. They do have a significant impact. The complication and rehospitalization rates are very high, up to 60%, with almost 60% of patients reporting severe limitations after treatment. There's a lot of basic questions that I think we still lack understanding. Certainly, which patients should have surgery and which shouldn't. If you're going to fix the fracture, what type of implant should you use? Should you use a plate or a nail? What's the role of arthroplasty versus internal fixation? And if you're going to use an arthroplasty, should you use a hemi-arthroplasty or should you use a reverse? So, how do you decide what to do? So you have this fracture pattern. Should you fix it or should you treat it non-operatively? So this is just an example, 78-year-old lady, retired, lives alone, has stable medical conditions, has this quite significantly displaced fracture. It was elected to treat this patient non-operatively. 3 months post-injury, she's got an excellent range of motion, minimal pain, and is fully functional. And then you have this patient, 75-year-old lady, very similar age, 8 months after an injury, she has a non-union and she's bitterly unhappy and required revision fixation to obtain union. So if you look at the evidence in 2021, there really is no evidence to support open reduction internal fixation in patients with proximal humerus fractures on average. However, I would say that we do know that some patients benefit from surgery, but it's really unclear who actually that is. So if you look, for example, at these x-rays and you have different, patients, so 71-year-old female, retired, 58-year-old man who's a laborer, 51-year-old gym teacher, 38-year-old banker and cyclist. Like, should the management be the same? And that really is the question. So it's a little more complicated than just trying to sort of decide, should all proximal humerus fractures get an operation or not get an operation? Certainly, if you look at the evidence, the evidence is probably the weakest in all of, I think, orthopedic trauma, pretty much in this area. So there's lots of studies that have been done, but we really don't have a good understanding of prognosis as it relates to the proximal humerus. Certainly, if you look at the current evidence, most of the randomized controlled trials looking at surgery versus no surgery in displaced fractures really don't show much benefit to surgery. This is a systematic review of almost 2,000 patients. They found no difference in function between operative and non-operative treatment, and actually found more reinterventions with surgery as opposed to no surgery, and recommended non-operative treatment for most elderly patients, described as being over the age of 65. And there have been some subsequent network meta-analysis done that's found exactly the same thing. The largest trial in this area, which is, I think, familiar to many of you, is the PROFOR-RCT, and this is a study that was done in the United Kingdom. Published in JAMA in 2015. It's the biggest trial in the area. They had 250 2 to 4-part fractures across all age groups, so age 16 to over 100, and essentially found no difference in functional outcomes, quality of life, or complications out to 2 and then 5-year follow-up, and essentially found that surgery cost more, so that non-operative treatment was actually a more cost-effective option. So based on that study, many have come out and said that surgery likely doesn't have a lot of impact in the management of proximal humerus fractures. But is that really true? So does surgery really have no impact? And if you're going to try and answer that question to the negative, why doesn't a large RCT published in JAMA not really help address the question? And I think this really gets to the notion that you really have to understand prognosis if you're going to design randomized controlled trials. So in this study, the PROFOR randomized controlled trial, they have 250 patients, largest RCT to date. But if you look at how they got those 250 patients, they basically screened 1,250 patients to get the 250, and then excluded a number of patients. So excluded 87 patients with a clear indication for surgery and 117 patients because of a lack of clinical equipoise. So if you're actually excluding patients that have a clear indication for surgery, that would suggest that surgery has some role to play in the management of a proximal humerus fracture. So they recruited only 20% of suitable fractures. They had a number of sites, but there was only, on average, around 5 patients at each site and 1 patient per surgeon. And surgery was lumped together different kinds of operations: plate fixation, hemiarthroplasty. So there wasn't one consistent surgical treatment. The study also didn't include a reverse, which I think has a large role to play in proximal humerus fracture management in 2021. The primary outcome, the Oxford shoulder score, is something that you'd use in elective surgery of the shoulder, not necessarily designed for trauma. And as a result, if you look at this study, many surgeons have actually expressed criticism of the conclusion. So even though it's the best evidence out there, supposedly, there's a lot of issues with this clinical trial. And it really has not been able to change practice. So for example, it's a study done in the UK looking at the PROFOR criteria, looking at 110 patients, and looked to see how they were treated. And in that study group, 75% of the patients should have been treated non-operatively if the PROFR conclusions were followed. And that study essentially concluded that there may be benefit in specific subgroups, and the PROFR trial didn't really address dealing with those subgroups. Certainly, if you look at proximal humerus fractures in Ontario, we've done some work with the Institute of Clinical Evaluative Sciences, and you can see with each randomized controlled trial over time, there's really not been a big, huge change in the number of patients that have undergone surgical intervention. So the rate of surgery has stayed relatively constant despite a number of trials which have shown that there's not a lot of benefit to surgery. And certainly, you know, if you look at what surgeons are doing, if you survey you know, surgeons across the country, the views in terms of how they should be managed are, you know, relatively fixed. So for example, two-part fractures, there's a real preponderance to open reduction internal fixation. You know, fracture dislocations managed either with open reduction internal fixation or a reverse. You know, head splits being managed with arthroplasty. So there are a fair number of patients getting surgery, and it's really only the minimally displaced fractures where surgeons feel that there's no role for surgery. And that's despite the fact, if you look at, again, ICE's data, this is data from Ontario looking at over 20,000 proximal humerus fractures, complications are actually the lowest, you know, with non-operative treatment. Now, obviously, there's probably some selection bias. The more seriously injured patients may be getting surgery, but you can see with non-operative treatment, the reoperation rates in general, you know, are relatively low, suggesting that, you know, perhaps we should be looking a lot more at non-operative treatment. But then I would also argue that surgery is needed in certain circumstances. And I think if you look at, you know, the literature, again, you know, the level 1 evidence is not necessarily there, but, you know, certainly if you look at case 4 series, you can see that, you know, there is a benefit to surgery in fracture dislocations, you know, patients that have significant soft tissue compromise, you know, valgus impacted fractures, head splits, and where there really is significant head shaft displacement. I think expertise is really critical in managing a proximal humerus fracture, and these are factors that have been shown to have a major impact. And if you're not dealing with these factors, then outcomes tend to be suboptimal. Expertise does play, you know, a large role. The quality of reduction and functional outcomes are related to, you know, surgeon experience. And this is a nice trial that showed that if you're not doing a fair amount of shoulder surgery every year, your outcomes tend not to be as good. So there's more to it than just sort of defining the appropriate patient. So, you know, expertise is critical. This just shows, you know, a fracture, well reduced, that goes on to uneventful healing. Here's another fracture where the calcar is not as well reduced and there's no calcar screw, and this patient goes on to collapse and displacement and required revision surgery. If you lose the tuberosity when you fix a proximal humerus fracture, that's an absolute disaster. And again, you know, is a technical issue that may be completely independent of patient selection. I think that, you know, when you're doing the surgery, obviously having the technical expertise is important, but locking plates and internal fixation are tools, not principles. And it's really important to have the appropriate patient selection, do a good job, and make sure the patient actually is a good candidate for rehab. And if not, then you wind up with x-rays that look like this. I think implants have also, suffered in terms of being associated with outcomes. I think one of the issues that we still struggle with, in 2021 is ensuring that the tuberosity is well fixed. And I'm not sure that many of our implants are able to appropriately deal with this. So what do we do? What do we know in terms of managing a proximal humerus fracture? Well, I think there's a lack of agreement on prognosis and predictors of outcome. So it's really hard to design randomized trials to give you the evidence when you don't know the patient population that should be recruited into the trial. There's a lack of agreement on classification of these, injuries. You can even see that in the case that was presented, and what the ideal outcome measures should be. The management options are not very straightforward. They're quite complex, and expertise is extremely important. I think what we have learned is that we really need to understand current practice, the population and its subgroups, and what the predictors of outcomes are before we design new RCTs. We need to understand the role of patient, fracture, treatment, surgeon, and rehab factors, and how they play a role in determining outcomes. And then we need to understand, why it is that when we're doing some of these trials, patients are regularly excluded. Because if you go back to that PROFER trial, understanding why it is certain patients were felt to be candidates for no surgery versus candidates for surgery, I think having that understanding is going to really help us in terms of managing these patients. I think, population data can be, really helpful. This again is some, data that we've used from ISIS in Ontario, looking at over 60,000, proximal humerus fractures. And you can see there are machine learning algorithms that you can apply to these patient populations that give you an idea in terms of, who does better and who does worse with surgical treatment. And there are a number of factors that really play a role: age, the number of comorbidities, the type of surgery that was used. And I think these algorithms, I think, are going to be helpful going forward. I think it's important to really get it right. This just shows, again, data from ISIS. Patients who, had a primary reverse have a very low subsequent reoperation risk. Whereas if you do internal fixation and have to convert to a reverse, about 20% of patients have a subsequent reoperation. So getting it right the first time when you've made a decision to operate, I think is really, really important. We feel that, in terms of sorting a lot of this out, I think some of this is going to be solved with a cohort study. So we've designed this study called Decipher, that is a prognosis study. It's funded by CIHR and the OTA. And we're hoping that we're going to be able to determine actually what predicts function and outcomes in this patient population. So we're hoping to recruit 17 centers across the country, 750 patients, looking at all fracture and treatment types, going to collect standardized comprehensive follow-up data, and trying to identify what the predictors of outcome are going to be following each treatment type, and determine which subgroups actually do better or worse with specific treatment types. And I think, that's going to be really important, because it's going to actually allow us to identify the subgroups, I think, that are going to benefit from future RCTs. So in conclusion, we're still not sure who benefits from an operation. There are high failure rates with conventional fixation. Lock plating was not as successful as was hoped. And I think it's really important to remember that it's just part of the treatment algorithm. It's not the solution. Certainly, if you look at surgical methods, the ideal method is unknown. I think we're starting to see maybe an increasing role for the reverse, but I don't think that is the solution to all, particularly in younger patients. There really are a few high quality studies to guide treatment. In general, I think we probably should be looking more at non-operative treatment, and certainly for the average elderly patient in the more than 65 to 70-year age group, it's likely best, but not always. And I think really the future, certainly near future, is a large, well-designed prognosis study. Thanks very much.
Thank you, Emil. That was really great, and we really look forward to getting some comprehensive data out of your upcoming study. We'll move along now to Dr. Gardner and welcome him and look forward to your chat.
Thank you. Yeah, thanks, Emil. Really great talk, and some points I think that segue very nicely into some of these here. So pleasure to be following. So again, we've heard a little bit of the background on this, I think, but why is there a controversy? You know, and the issue is that, you know, as practicing surgeons, we've all seen that many patients benefit from ORIF or surgical treatment, but it's hard to find literature to support that. We heard the lock plating results are variable, really generally poor, with double-digit complication rates in most series. But a real main issue, and Emil touched on this, is that the quality of reduction is not accounted for in many of these trials, the ProFert and others. And then these randomized trials get grouped into meta-analyses, and this kind of concept just persists, that there is no benefit from ORIF. So here's an interesting paper you may have seen from 2019. A really specialist center, Mike Robinson from Edinburgh, and they found excellent short and long-term outcomes, better than non-operative treatment, very low complication rates, but they note that this is really likely a function of having a specialized service to treat these fractures, and really kind of showed a benefit of operative treatment. Granted, it wasn't a randomized trial. So when we step back and start thinking about how we decide, what we look at when we start to decide all of these things, and it will be great. That's a great case we saw at the beginning. It'll be great to discuss that, because that really incorporated, I think, a lot of the issues that we'll go through here. But some things that we try to, in our fracture conferences and things, try to kind of touch on, really just a mental exercise. Often there's no clear answer for these, but when we look at a fracture like this, is it likely to displace with physiologic activity? So imagine you're asleep with a fluoro machine and you range this shoulder. Is this going to move as a unit, or is it going to be independent? Again, often hard to know. Is it likely to heal? So sometimes if we have complete displacement between, for example, the shaft and the head, it's a very high non-union risk. So sometimes just the displacement between the fragments is a reasonable indication to consider surgical fixation. And then finally, if it were to heal like this, is that likely to impair their function? And this gets back to, you know, what the patient's desires are, but we like to try to anticipate what the function would be if this were to heal into a malunion. So that's a fracture assessment. Very important, obviously, and we usually see the x-rays right before we see the patient, whether it's in clinic or the hospital, but really it all depends on the patient. So as we start to talk to the patient, do they wish to have a functional outcome that looks like this? And really distinguishing lines we talk about are like elevation over shoulder level or hand behind your head. Like, would you be happy with just getting your arm up to head level? And surprisingly, many patients are. They say, you know, they don't have a need to get up over their head. They'd rather avoid a surgery. So step one, we're talking about patient assessment, really get to know the patient. And then step two, I think, you know, there's going to be times where, depending on the medical comorbidities and the patient function, we're going to be treating displaced fractures non-operatively. And so when we're describing the risks and benefits and alternatives to patients, we need to know, or we need to have some sort of insight into what the natural history is of displaced fractures treated non-operatively, both related to function and related to non-union risk. And then finally, we want to avoid the worst possible case scenario, which is this right here, where we have a fracture and a patient, and we think we have a technique and a tool to make them better, and we fail, and now we've made them worse. So we need to figure out ways to avoid this at all costs. So diving into that a little bit deeper, how do we avoid that? So the substrate we're working with is really one of the major problems here. The humeral head has been likened to a rotten tomato, a tennis ball, or even an egg. And there's another great analogy that Dean Lorich took pictures of one day. So, and this is really what we see clinically sometimes, right? In these osteoporotic patients that we go for ORIF, it's like an ice cream that just melts around our stable, stiff, locked implants. And this is problematic. So here's a 46-year-old male, relatively low surgical neck fracture in valgus, kind of 50% translation maybe, treated with ORIF, and heals without difficulty. And so this patient, probably there's a lot of room for error in terms of technique of reduction accuracy, implant placement, et cetera. And so we like to contrast that with this patient who's a 78-year-old male, alcoholic, found down. So I think we would all just kind of know that this patient is a higher risk for ORIF in particular. And so what is it about this patient? And so I think these are the kind of things that are needed in upcoming trials. And what are the details about this specifically? And we do have some literature to guide this, mainly from cohort studies, but these patients are clearly different. So it's very useful to try to risk stratify patients for implant failure. So we'll go through some of these now. And this Emil highlighted, which I would reiterate, if there's one underlying theme through all of the voluminous literature on proximal humerus ORIF, it's that there is a high complication rate without technical accuracy. So the lock plate is not a substitute for well-done surgery. So one thing we've seen multiple times is this issue of unsupported calcar comminution. So our plate's a lateral plate, really functioning like a tension band almost. The proximal screws are unicortical by necessity because of the articular surface. And so it's really disadvantaged mechanically to stabilize this situation. And this is a very strong red flag for failure risk. So calcar comminution is problematic, unsupported, or without some sort of augmentation. We've seen that osteoporosis is a very strong risk factor for fixation failure in many fractures around the body, but that certainly holds true, probably more so in the proximal humerus. Here are just a couple. This is one of the early studies on lock plates for proximal humerus fractures out of Rochester, New York. Patients over 60 years old, 57% complication rate and 43% screw cutout. It's hard to imagine why we would keep doing this operation, right? But, you know, this is the example of their paper that they chose to put in. And I think, you know, this was the first attempt at all of us doing this, but I think we would all agree that this is a suboptimal reduction and surgery. And then, you know, they note that this went on to failure and the lock plate didn't overcome this poor reduction. Varus is the kiss of death in many fractures again, but particularly in the proximal humerus. We see this over and over again. Here's again an early paper out of Denver showing 30% failure rate when the neck shaft angle was varus, and 11%, still pretty high, but 11% when it was in valgus. And of note, and this is another common theme throughout these papers, because people think, well, we want to hold the head, we just need to add all the screws. And I haven't seen one good study that's shown the number of screws correlates to failure risk. So just something side to keep in mind. Another really interesting paper from Southern California, 70 patients over 55, and in their varus fractures, there were 79% complication rate, 21% risk of perforation of screws, 13% reduction loss. Interestingly, they kind of have in fine print in their discussion, 71% of these patients were malreduced. So I think it's outstanding of these authors to recognize and report that. But it also raises kind of the question, right? Is it just that these fractures are harder to reduce, or is it they're harder to hold once reduced? And probably it's a little bit of both. All right, another predictive factor of failure, malreduction, and especially varus, but all methods of malreduction, as we've talked about, are put the patient at risk for failure. And then this is something that's just kind of, there's not a lot of literature on this now, but this actually generally is one of my strongest kind of weighted factors for deciding, at least between ORIF and arthroplasty. And this is what I think a CT scan is most helpful for. And it's evaluating particularly the thickness of this head fragment. Sometimes you can see it well in an X-ray, but sometimes you can't. And you see on these 2D and 3D CTs, how thin this head fragment is. And so we know we're going to need to hold these fragments with the tips of lock screws. Sometimes we can add cement, and there are some other new devices, but when we get a shell of a head fragment, that's going to make it really hard to hold. And this is a good situation, I think, to start thinking and talking about arthroplasty. All right. So with these factors of risk factors for failure in mind, what are some things we can do to offset these? Some of these things are not in our control, but anatomical reduction helps. And so here's a patient who we fixed, and what we're looking at is this right here, this calcar continuity. Now, sometimes it's comminuted and we can't dock the bone ends kind of side to side, but we like to get as good of apposition as we can. And then we're looking at this neck shaft angle. We can't measure it on a fluoroscopy machine typically, but we want to make it look like a proximal humerus. We talked about the calcar screws. So here's what we're talking about. I think Emil showed this, one of these series that with the blue arrow, that was from this paper where we looked at the presence or absence of medial support, whether that was edge on edge apposition or intussusception or calcar screws. And if patients did not have any medial support, they were at substantially higher risk of failure, and no other factors that we looked at were predictive of failure. Cement augmentation can also help, and there are a few studies on this. Ken Eagle has kind of the most high profile one out of New York. This is the indication that I use this for most often, 82-year-old female, a valgus injury. And so you see here, we get an elevator under the head, and when we lift it up, our tuberosity is very comminuted, but there's also this impaction zone in the metaphysis. So there's going to be no mechanical support to prevent redisplacement of this head fragment back into valgus. So this is, I think, a good time to fill this up with cement, just to give it a stable platform of high initial compressive strength to kind of rest the head fragment back onto. And this is that patient in 3 months, healed and doing well. We've also learned more and more that a fibular strut allograft can help, and the indications for this aren't fully clear. I'll just show you one case, and this is, again, my most common indication, but varus patterns with patients with osteoporosis with medial comminution. This is a good time. So we lift the head back up, try to dock the medial side. And then we just, through a deltoid split approach, we kind of pot the fibula into the canal and then retrograde, kind of mallet it using this K-wire as just an axilla to really impact it into that medial head. And then here's just a picture of the fibula going in. You see, we've had to shorten the fibula because we like it to tilt medially, because in this application, we think this is really the best biomechanical place to put this. And then once this is in, it's hard to miss it with lock screws. So we shorten the lever arm of the screws, we augment that medial column, and we're really now at a nice stable situation with our implant. And just another kind of thought the fibula can work well to substitute for the calcar. So here's a patient that had a big calcar fragment. Again, high risk if we weren't to do anything and treat this with a lateral plate alone, but we can substitute the medial cortex, hold that with screws, and then she goes on to remodel exuberantly on her medial side with callus. So just some thoughts on indications for me, displaced fracture in a patient that I think I can obtain and maintain a good reduction. And that's, again, knowing our own skill set, our team around us, our fluoro team. Is really a lot that goes into that. We need to make sure it's the right patient that can participate in rehab to make the functional outcome potential worth the risks of surgery. Of course, we need the patient that is medically stable enough to tolerate a surgery and has functional demands that warrant kind of overhead activities. And just in summary, when we choose ORIF, we need to avoid varus. We want to try to establish the medial calcar, and then in complex cases, we can think about augmentation, whether it's a volume of cement of some sort or a more cortical fibular strut allograft in various positions. And so that's it. Thank you very much.
Thanks very much, Dr. Gardner. That was amazing and some really great cases to show, particularly in supporting the medial calcar. I just want to know if anyone had any questions before we went on to some further cases. All right.
Okay. So I've got a few more cases here, and sorry for the feedback. But those were excellent talks. So how about Nolan? Nolan, I've got a case for you here. Here we go. This is a sharing is paused.
John, I think you might just have to exit a full screen or.
Yeah.
Maybe just while we're getting that up there, I got a question to kind of get some discussion going. Emil, I think you showed a slide where it was how the evidence has been taken up with the proximal humerus in terms of the UK and how you say maybe compared to clavicle type of research that's come out. What do you think is the contrast between that, or do you think this is a similar issue, and how do we alleviate?
Yeah, I mean, I'll just a couple comments on that. I think the big difference is that there are so many more fracture and patient-related nuances to decision-making and prognosis in proximal humerus fractures that we've kind of heard for the last half hour. And the big problem is those don't get accounted for in the proximal humerus trials, and contrast that to the clavicle fracture where, sure, there are fracture variations, but generally, there's a mid-diaphyseal clavicle fracture that's comminuted and displaced, and there probably aren't many more factors that are important than that, so there's not a variety of fracture types that need to get kind of parsed out correctly.
Yeah, I would agree with that. And I think, patient factors play a massive role. I think, clavicle fractures often, occur in very active young people. Whereas, we're not talking about clavicle fractures in 60 and 70-year-olds. Whereas proximal humerus fractures, the radiographs often look terrible, but you then look at the patient and then, try and figure out why it is that you'd be thinking about operating in a patient that, potentially has poor rehab potential, has multiple medical comorbidities and so forth. So typically tends to be an entirely different patient population. And I agree with, Mike, it's a really, complex injury that's got so many factors at play that makes it really challenging to, drive any sort of meaningful conclusions from the literature.
I think that's good. It's good to think about as we step into this case now. I think it's working up and running, John.
Yes, sorry about that. So Nolan, here we've got a 54-year-old cyclist, and they've got this isolated injury. You've got these 2 X-rays. Can you describe them and let me know what you're thinking in terms of treatment options here?
Yep. So AP and lateral views showing a fracture of the proximal humerus with comminution. Definitely appears to be comminution. Can't say for certain exactly how many fragments it is at this point. Bone looks somewhat osteoporotic as well.
Okay, so what would you like to do next? Do you want any more imaging? Do you have a surgical plan?
So the patient's 54-year-old, relatively high functioning. I talked to them about operative versus non-operative management. Right now, it's kind of an unacceptable alignment. We could try a week with a hanging arm cast to see if it looks a little bit more appropriate, or if the patient has a preference towards operative management, I'd arrange a CT scan to be done for preoperative planning.
Sure. So they said they might be interested in surgery, and so you get a CT scan. And what do you see specifically on these views? Does that change your thinking? Can you describe what you see?
So select sagittal and axial cuts, showing extension into the articular surface with a small articular step. I'd have to look through the cuts a little bit more thoroughly, but looks like there's a separate GT fragment for sure as well as I suspect it's a little bit hard to say. It looks like there might be a fracture line going through the anatomic neck that's undisplaced, but once again, I'd have to look at all the cuts.
Yeah, good. I think that you see the pertinent things here. So there is a bit of maybe we could call it a head split, maybe. The GT is involved, but the major fragment, you're right, is the kind of below the surgical neck. So what's your treatment suggestion here?
So like I said, if the patient had a preference towards operative management,
yeah.
My plan, 54-year-old, would be, I put on the consent open reduction internal fixation with a pre-contoured proximal humerus locking plate. But I would also have discussed with the patient possible hemiarthroplasty, just in case I got in there and found that the bone was non-reconstructible.
Okay, I like that plan. That's good. This was actually done by one of your graduates, not myself, recently, and we spoke over the phone. They were asking my advice, and I said, you know what, there is a head split there. I would consider maybe not a typical through and through, vertical split, but if you could get this reasonably well aligned with a plate and there's good tuberosity healing, I think this has a very good chance of doing well. What do the panelists think of this decision and this treatment? I'm curious.
Yeah, I agree, first of all, that this is the true head split. There are a lot of fracture patterns now that we're getting more CTs where the fracture line extends into the articular or contains some of the articular surface. Typically, it's the anterior fragment. But, dogma has changed where, this is not just because it's a head split. This is not a knee-jerk arthroplasty. We can fix these effectively. So I would fix. I would not have an arthroplasty in the room. I agree. It looks a little osteoporotic, maybe more than you'd expect on X-ray or CT. But this a cyclist in his 50s. This is not someone we're gonna, I think, be surprised with extreme osteoporosis. And so, I think it works well from the lateral approach. You can kind of shift those pieces, and if you can find the right fluoro view rotation to profile the fracture, you can get them realigned pretty well and wired, and then reduce the neck part of it and a plate like this. And this looks pretty good.
Yeah, I agree. Would you be thinking about an augmentation or anything for this pattern?
Yeah, I would not actually. So this one, there's some medial comminution, but it's a pretty low neck fracture. And, so if you get it out of varus and you can get it kind of docked, this is not one. I think it'd be reasonable to, if somebody wanted to or whatever. I don't think it's, but I think it's with a good reduction, a plate in this patient, in a 54-year-old patient, a plate alone will work fine.
And what about sutures? Do you think sutures play an essential role, or are they optional in this type of pattern?
You know, I put sutures in almost everybody. I mean, a simple fracture like a 20-year-old, I don't, but and there's one paper that showed it didn't make a difference. And I respect the biomechanical evidence, but I hope it doesn't dissuade majority of people from using it, because it really only, if you put a bunch of sutures in the cuff, it provides a little bit of a tension band to bypass the stress on the screw tips. And so I think it can only help. It doesn't take much. And so I would.
Mike?
Schemitsch, anything to add?
No, I was just going to ask Mike, is there any circumstance intraoperatively where you would convert to an arthroplasty in a case like this, or would you sort of persist?
You know, I haven't had to do that in hundreds of cases, and not that I haven't had patients fail, of course, but it's just, you know, what you need to see. I guess the one situation where it gets close is if you really have like a disc of a head that's free of soft tissue and just spinning, and you can't see where it goes and you can't hold it. You know, that's one time, but, you know, short of that, but that, you know, now we see on CT scans and we prepare a little bit. So I think with our understanding and our preparation and our CT scans and lectures like this, you know, we really don't get surprised anymore. There are plenty of patients I send for arthroplasty because I think they'd be hard to fix, but, you know, with the appropriate planning, once we get in there, we just kind of do what we do.
Yeah,
I was just going to ask, are you a lateral split all the time kind of guy, or do you go deltoid pec for any of these patterns?
Yeah, I go lateral split all the time. If the lesser tuberosity is retracted far medially, that's hard to get. So those sometimes I'll do a delta pec. If it's a trans kind of or juxtathoracic dislocation, I think you really need to do a vascularly extensile approach. But that's about it otherwise. But you know, again, I always say like, it's easier for me, but that's just because I do it more. Like there are people who only do delta pec, and so they're hard enough as it is, and you need to get used to doing something like in a standard way. And same with the sequence, you know, a lot of sequences you can do. It's just, you need to get used to doing it a certain way. And that's the only way it becomes kind of, you know, easier.
Well, I think that kind of speaks to like the expertise factor we talked about in some of the earlier portions of the talk. And I mean, Emil, in your center, you have the Hulk there, or like with timing and whatnot. Are you guys trying to stick handle these to that specialty center, or like would a case like this be done anywhere?
Pretty much most of them would go to Hulk, just because that's all they do. And as a result, you know, the outcomes are going to be better. So they typically would go there. Something straightforward would be done at Vic, but the more complicated stuff would go to Hulk. Just wanted to ask about what do you think of that RCT that looked at deltoid pectoral versus a deltoid split and actually found better results with the deltoid pectoral, the study from Montreal by Dominique Rouleau?
Yeah, so I reviewed that on the OTA podium and I moderated and I asked some of the questions, but as you know, it's hard to get too much into it in a minute. But yeah, you know, I mean, my one criticism of that, which she appropriately acknowledges, is, you know, so I talked about the importance of the calcar screw. So what drove the worst outcomes in the deltoid split approach were the increased number of failures. And they had far fewer patients with calcar screws. And so, you know, you need to put calcar screws in through a deltoid split approach. And you do that by finding the nerve and moving it out of the way. And so if you just do true 2-window perk, then you've got high screws in the head and shaft screws, and that leads to more failures and worse outcomes regardless of the approach.
Agreed.
Okay, I think we're pretty much done. This has been a really fantastic talk. I've learned a bunch myself. I've got some more cases for the residents, but I think they can go through those at another time. I think that I've got a few resources and just a little shout out to the AO, because they have a really fantastic, I'm trying to find it here, fantastic technique sequence. So as Dr. Gardner is saying, you know, you've got to find your way to march through these cases and get these sequences and steps. I think most of us will agree for 4-part fractures, 3-part. The steps are all very similar and reproducible, so you can get good at it if you practice it. And the AO surgery reference for this is really a very good reference. So I recommend the residents check it out. They've got some fantastic diagrams and steps.
Awesome. And I just want to say thanks, John, and thanks, Heather, for going through the cases and helping to moderate, and Mike and Emil. I think this is a great session to have in relation to the value one we had a couple weeks ago, and in talking about how the patient decision and input comes into how you're going to decide. And, think about that, how it relates to timing and then the center and how these patients get sort of put through the system. And I think, talking in places where there are specialty centers, it's really important to have that discussion as we decide how we're going to treat these. So thanks for bringing up those points. Thanks everybody for joining in. And next week's session is going to be up on Thursday. We're going to be talking about some open fractures, and then we'll send out some more info out in the next few days with that. So I'm going to have some great panelists and some good discussions there. So looking forward to tuning in next week, and thanks again, everybody.
Great. Thanks, guys.